2020 Connect. The title of this symposium is Magic Touch Sirolimus-Coated Balloons, Clinical Updates and Potential Advantages. I work at Columbia University in New York City and the Cardiovascular Research Foundation, and I'm very fortunate to be surrounded by a wonderful faculty with great experience on this particular topic. Next. These are my disclosures. This is the program agenda. I'll make some initial opening remarks, but then we'll focus on the content of the program. We're going to begin with my good friend Antonio Colombo, who will put in perspective the use of drug-coated balloons in clinical practice, showing us some case examples. Then we'll move on to Bernardo Cortese. He's got enormous experience with Magic Touch Sirolimus-Coated Balloons, and he's going to enlighten us as to the potential advantages over Paclitaxel drug-coated balloons and present some of the current data. Next, we're going to have Sandeep Basavarajaiah, who's going to talk more about Magic Touch Sirolimus-Coated balloons in the context of treating real-world patients with an emphasis on clinical cases. And then we're going to conclude with Professor Serruys, who's going to enlighten us and in a very important and interesting way bring some of the academic features to light by discussing the Transform-1 randomized clinical trial, which will be a comparison of sirolimus versus Paclitaxel coated balloons in small vessels in de novo coronaries. The objectives of this session are to provide a really updated perspective on the use of drug-coated balloons in clinical practice, and then to do a deep dive into the specific Magic Touch Sirolimus-Coated balloons, emphasizing some of the advantages compared to Paclitaxel, some of the current clinical data, real-world case examples, which I think will be very meaningful, and then the important future clinical trials that are planned. The Transform-1 RCT in Europe, and also I will tell you that we're preparing right now an FDA pivotal clinical trial in in-stent restenosis for the United States.
In current practice, I have no conflict to disclose, and we all know current treatment of in-stent restenosis and PCI or small vessels are the main areas of usage of drug-coated balloon. And I will skip these two fields. You know, a lot of presentations are available on the web, and I really don't want to be repetitious. So just take these two areas for granted, clear. We accept that drug-coated balloons are useful in this area. Something relatively new is this concept. When you have a focal stenosis with a low FFR, you can implant a short stent, expect an improvement of the FFR after stenting, and basically a good outcome. This is a perfect area for stenting. But when you have an LAD with long diffuse disease, it's sometimes difficult to pinpoint the area where there is a significant lesion. The FFR is low, but is diffusely low. I'm not convinced that this type of disease is ideal for stenting. So I would like to introduce the concept of DCB with FFR evaluation and maybe no stenting or focal stenting. Look at these long LED like the one that you showed with the follow-up of occluded long stent. I do not believe that this is contemporary interventional cardiology. I did these procedures a few years ago, and I really do my best to avoid doing them again. Unfortunately, the operator treated this diffuse disease in the OM in the same fashion with the long stent, and hope the follow-up will be better, but I'm not so sure. I would like to use drug-coated balloons and contemporary technology for a new approach. This is an LAD with proximal disease and the long diffuse disease distally. A good surgeon can certainly do a good job, but is not the ideal for surgery, even if feasible. Usual angioplasty, lesion pre-dilatation, high atmosphere, the balloon does not expand. You use adjunctive technology. In this case, IBUS confirmed the presence of calcium. We use lithotripsy. Then we use cutting balloon to improve the result. Then non-compliant balloon, high pressure, treated the side branch with a kissing balloon. And then after appropriate lesion preparation, you see good result proximally, a dissection distally. The first reaction is to place long stents. We try to stay away. We place a relatively short stent, 24 millimeter proximally, and then we start working on the distal. The distal, you see a dissection, you see a focal critical stenosis and some diffuse disease. We do physiology evaluation, PAPD 86, 84 more distally, contrast FFR 77 to make the procedure more simple. Distal, of course, is still ischemic. We dilate better, then we do drug-coated balloon distally, long, 2.5, 40. The result is better. There's still a dissection, but we don't want to leave dissections just because they look acceptable. We repeat physiology evaluation, PAPD is 94, and FFR contrast is 87. So this result is acceptable even from the physiologic point of view, and no stent is placed and drug-coated balloon is sufficient. This is the final result in 2 projections. This patient now has quite a long follow-up, and we hope we can get the follow-up angiography. This is another case example. Bifurcation LAD in a lady with a lot of diffuse tortuous disease distally. We do QFR, which is all red. Index is 0.62. I don't think you really need subtle measurement to discover that you are dealing with diffuse disease. We treat with semi-compliant balloon more distally, cutting balloon proximally, protecting the diagonal. We do IBUS to check appropriate vessel size, contemporary angioplasty. We do further dilatation distally, and then we do magic touch, sirolimus more distally, more proximally, and this is after just balloon. There is a dissection in the mid part, everything else is just drug-coated balloon. We repeat the QFR, which is not red anymore, only the very tip of the figure is red, but everything else is very acceptable. The 6 months follow-up, we are fortunate that this lady stayed totally asymptomatic. On the left, the end of the procedure. On the right, the 6 months follow-up. Look at the geometry of the vessel, no stents, perfect healing, good, nice, positive remodeling. This is another projection, end of the procedure on the left, 6 months follow-up. So what is a newcomer? The newcomer is the post-PCI FFR or post-PCI PDPA. This is the recent study by Shin, 580 patients with measurement post-stenting. The problem here is that no target vessel failure in blue and target vessel failure in red. FFR or PDPA, if is better after stenting with the p-value, the follow-up is better. But if you look at this slide, you see a lot of overlap. So it's not a guarantee if it's better after stenting, but the truth of the matter that after stenting, is important the lumen gain, because your results are mainly based on lumen gain and minimal late loss. With drug-coated balloon, we use physiology with a different purpose. We use physiology to exclude the risk of occlusion. We welcome some type of dissection because it tells us that we had optimal dilatation, and the presence of this dissection, we hope, will facilitate positive remodeling. We are collecting data. We hope that next year I will be able to present a series of more than 100 patients with long-term follow-up, at least 1 year, to state that this concept is true. So these are not a universal solution. These are essential, but in some setting, like long lesions, diffuse disease, we need a different approach. We need to move away, if we can, from excessive usage of long stents of full metal jacket. With this, we hope for minimal lumen loss. With DCB, we also hope for lumen gain.
Antonio, thank you very much. That was certainly very provocative. So Antonio is proposing yet another use of DCB. You remember for diffuse disease, we had gotten into a routine of DES, what we used to call full metal jacket. And now we're back to what Antonio innovated a long time ago, which is spot stenting. And in fact, as much as possible to avoid stents. But Antonio, again, to me, this is very stylistic. You're encouraging dissections. You're using physiology to make sure that there's still restored flow in the artery. But it's hard for me to understand which areas you would stent and which areas you wouldn't. Is it based on physiology? Is it based on IVUS? Is it integrating all of those with angiography? How do you deal with a dissection that is difficult to predict what direction it's going to be going in?
Okay, very important. Let me tell you first that we do not want to go against stenting, okay?
Right.
It's not a drug-coated balloon versus stent. Let's make it clear. We love stenting, and thanks God stents are with us. Most of the time, when we have evaluated these dissections, if there is a need to stent, we prefer to stent, and sometimes even long stent. Our practice, and so far we've done a fair number of cases, about 30 cases, we have seen like a dichotomous. The dissection is benign and you don't need to place any stent at all, or a dissection is not very good and you need to stent. So we rarely have used the spot stenting. Most of the time we've used the stent or no stent. So we still need to explore, but I'm sure that in some cases you will need to do some focus stenting, and I believe if you do that, you need imaging.
Very exciting initial lecture. I think what we'd like to do is move on, and we're going to go on to Bernardo Cortese, and he's going to begin sharing some of his experiences with Magic Touch. Contrast sirolimus versus Paclitaxel, present some data, maybe show some cases. Bernardo?
Yes, thank you. Thank you. Okay, well, when I started doing this presentation a few days ago, I wanted to design it around a young interventional cardiologist. So this is an interventional cardiologist asking me, so what do I expect from a DCB in 2020? The first answer is a safe device. And so to answer this question, I think we should start from this meta-analysis that probably you know. This was published a couple of years ago, almost 2 years ago, by Katsanos, and it showed that Paclitaxel-coated devices, either stents or DCB used for femoral popliteal PTA, were associated with an increase in total mortality after 2 years. And some of them, just actually a few studies, 3 studies, after 4 to 5 years. This meta-analysis has severe flaws from the methodological point of view. We already discussed about this. But the first point that I want to underline is that after 1 year, there was no increase in mortality, no reduction, no increase in mortality with all of these drug-coated devices. We have to admit that Paclitaxel is toxic. This is something that Rino Virmani is saying in the last 10 years at least. She told me last time I met her, Bernardo, Paclitaxel is toxic. Yes, probably she's right. We have seen this. These are the collateral effects that we can see in cancer patients. We know that bone marrow toxicity is the first organ that is associated with this toxicity. But we also have to admit that Paclitaxel given by means of a DCB has a totally different kinetic if compared to Paclitaxel given intravenously for cancer patients. For example, we have these two previous versions of DCBs which were put into the meta-analysis of Katsanos that show that the area under the curve in terms of dosage of Paclitaxel administered was much lower than the one that is administered by means of cancer patients. And we have also seen from this a patient-level meta-analysis that there is no correlation between the total dosage of Paclitaxel given in the legs and mortality. Here, patients were divided into 3 groups according to the total dosage of Paclitaxel given, at least the theoretical Paclitaxel given in terms of dosage. On the other hand, we have clearly shown that there is an increase in mortality and in stent thrombosis when Paclitaxel is given associated to a stent. We have seen this with the first generation of drug-eluting stents. The thrombosis that was found into this autopsy study was quite high, even if it was not a clinical relevant thrombosis, but 27 of the patients showed some thrombus on the stent months or years after the implantation of the stent itself. What about the coronary theater? Here we have better data. There was no increase in all-cause mortality after 3 years in this meta-analysis published this year by Bruno Scheller and group. And there was also a reduction in cardiac mortality after 3 years. So at least the coronary theater seems spared by this increased risk in mortality as shown by this meta-analysis of Katsanos. So just to be very clear and very honest, I took this slide from Juan. What we know when we use a DCB in the periphery is that we know the total concentration of Paclitaxel and we know the length of the balloon that we are using. However, all the rest of the variables are really different. We don't know how much drug we lose during the transit, the manipulation of the devices. We don't know actually how much of the drug is delivered to the vessel wall. We don't know how much drug is retained on the balloon. And then we also have the problem with the distal embolization shown with the first generation of Paclitaxel-coated balloons. So it is quite difficult to understand and to know the actual dosage of Paclitaxel given to a patient, especially when we use long balloons, a long device in the periphery. Now we have an alternative. The alternative is Sirolimus. Paclitaxel and Sirolimus are quite different drugs. Paclitaxel is a cytostatic drug which becomes cytotoxic when we go out the therapeutic window, whereas Sirolimus acting on mTOR is just a cytostatic drug. In this slide, there is a resume of the different characteristics of these two drugs. The first point is that they are all able to inhibit muscle cell proliferation and migration. This is in common between the two drugs, but What is quite different is the therapeutic range. As I said previously, Paclitaxel has a very short therapeutic range. If we go out of this range, the drug can be toxic, whereas the safety margin of sirolimus is much higher. Then sirolimus also has some anti-inflammatory properties that Paclitaxel do not share. However, on the other hand, it is very difficult to create a correct device with sirolimus, eluting the drug in an efficient way. And so that's the reason why it took almost 9 years before having the first DCB eluting sirolimus coming into the European market. The second question in interventional cardiology can ask us is, how does Magic Touch work? Because I need to know some basic data about the device that I'm going to implant or to use in my patients. And now we have a very strong technology. As I said, it took 9 years before having this technology out for our patients. We need to protect and to encapsulate sirolimus in some dedicated nanospheres that will help this drug to enter the vessel wall and to stay there for the first weeks after the use of the device. The technology behind is quite complex and quite different. We are not engineers, but the studies that have been done are really reassuring in terms of the safety of this device. I took this slide from Aloki. Aloki showed clearly that in this animal study, there is no drug in the blood after 1 month, and this is not the truth when we apply some first-generation Paclitaxel-coated devices. And then we only have the drug after 1 month in the segment which was treated, but we don't see any drug in the proximal and in distal sections and in the surrounding myocardium. And then we cannot detect any drug, any sirolimus in the other organ of the animals used for this study. And then the next question, how is deliverability, not of the device, but of the drug? Because, okay, the balloon may be good, but we want also to deliver the drug correctly. The first point is that you have to work on the device, and the Concept Medical worked on the device. And these are some cases that I put here. These were quite complex patients that we decided to treat by means of only DCB PCI, and we were able to manage this with this final result. And this is another patient with very tortuous vessels that wanted to be treated by only DCB PCIs. And this was the final result, and we had no specific issues in delivering the drug correctly to the vessel wall. And then another question, how is the late lumen loss? This is a surrogate endpoint, but we need to know this, especially in native vessel disease. And we have this data, we have this study in 27 consecutive patients treated with small vessel disease. And what we have seen in the Phasico-native study was that the late lumen loss was very good, with like the best-in-class PCB, it was 0.09, with only few patients with person stenosis more than 50%. Do we have long-term data with Magic Touch? Yes, now we also have some long-term data. We have here the 2-year data for the ISR nanolutations, which show no late catch-up between 1 and 2 years in terms of hard endpoint. This was a study done only in Indian patients. And we also have this data, which is not been published yet, but will be presented during TCT this year. In Indian patients, we have the 3-year data, small vessel disease treated by Magic Touch. And also here, we don't have late catch-up in terms of target vessel MI and target lesion revascularization between 1 and 3 years. Okay, but the next question is, we need also strong clinical data, so an investigator-driven, all-comer study, multinational possibly. We are trying to give an answer also to this question with the ISMO registry. This is an all-comer worldwide registry, which will finish the enrollment of the patient very soon. This will be a prospective, multi-center, as I said, investigator-driven clinical registry with 3-year follow-up. And we can share some preliminary data with a 1-year interim analysis, which was presented during TCT last year and which was published this year. we have this data at 12 months, 1% total death, 2.3% MI, 2.5% target lesion revascularization, and a total MACE rate of 5.8% with no bleedings. What about the ISR cohort? ISR is a setting where Paclitaxel is not working very well, at least not like the latest generation drug-eluting stent. Also here we have very good data, 1.8 MI, 5.4 TLR at 1 year, and 8.6% of MACE. And now we are very close to the goal of finishing the enrollment of this, which will be the largest study on DCB ever. We will reach the final population of 2,100 patients, hopefully very soon, within 1 or 2 weeks. And then we have the last question. This is the big one. Is there any comparison between Paclitaxel and Sirolimus for the coronary theater? Also here we have some preliminary data. I'm going to show you this data which I presented during EuroPCR this year via the web as a late-breaking trial. This is the SIRPAC study, 1,000 patient study, an indirect comparison between the ESPOR interim analysis and the DCB Serruys study. We show no differences in terms of MACE and TLR with very good clinical outcome at 1 year between the Magic Touch and one of the latest generation DCB eluting Paclitaxel. So my conclusion, first of all, Cazzano's meta-analysis was really an earthquake in the field and in interventional cardiologists which are dedicated to this type of devices. However, this meta-analysis is flawed by major statistical drawbacks. We have to admit this, but some biological plausibility about the effect in long-term mortality by Paclitaxel should be very deeply investigated. Newer devices and better designed randomized clinical trials with long-term follow-up are really needed in this segment. Magic Touch is the first Sirolimus-Coated balloon that now has a CE mark for coronary, peripheral, and AV fistula, is showing very promising data and is already leader in the market in many European countries. Now we will see which will be the next studies with this device.
Bernardo, that was really excellent. A very, very thorough presentation. And it really helps the audience have a good understanding as to the evolution from Paclitaxel to Sirolimus and some of the technology that's embedded within the Magic Touch. We could ask many, many questions. You presented the data very elegantly. I'll give you some of my reactions just to get your feelings. I agree that Cazzano's meta-analysis was an earthquake, but as you mentioned in your conclusion, it definitely was tainted by some significant statistical flaws. And I will tell you that I'm not certain that there is significant systemic toxicity, especially in the coronaries with a Paclitaxel-coated balloon. That, I think, needs to be further explored. There are many other studies that are ongoing that will answer that question. I was a major advocate of Sirolimus for now 25 years. So I agree that I believe Sirolimus has certainly has a larger therapeutic window, is a safer drug, has many positive features. But you mentioned the negative aspect, which is it's difficult to get intracellular or across vessel walls, and it's difficult to be retained in the vessel wall. So the interesting aspect of Magic Touch is to solve that pharmacokinetic problem by developing these nanoparticles that are absorbed within liposomes. And I think that's a very interesting solution to some of the drawbacks of Sirolimus. I will tell you that the data look encouraging, but to me, they're not definitive. I don't think we have enough late angiographic follow-up to speak in a meaningful way about what the true late lumen loss is under various circumstances. Diabetics, small vessels, long lesions. I think we need more late data. And I think that we need to do more direct comparison studies to get a better understanding of whether or not a Magic Touch Sirolimus DCB is going to be either better than Paclitaxel or as good as a stent. I think we need more data, which is what we're trying to achieve and what Patrick is going to be proposing. But it certainly is is a very provocative scenario that you have presented. Another question I had for you was, what are you doing with dual antiplatelet therapy after Magic Touch? What is your routine?
Yeah, well, first of all, I have to admit that I agree with you. Paclitaxel is not dead, but in my opinion, first generation Paclitaxel-coated balloon should come out the market because they are not safe. The latest generation, some of them are a little bit better, but I have to say that the strong clinical program, which is around Magic Touch, which had the CE mark only 4 years ago, we have to remember this, is very high. And we are still halfway, okay? There will be more studies, larger studies with clinical endpoints, you know that very well, that will confirm not this data, which are not only preliminary, but still we are halfway. Regarding your question, well, we usually give just 1 month of dual antiplatelet therapy in elective patients. In case of in-stent restenosis, we go up to 3 months, but we also have some experience in some patients at high bleeding risk. We give the Magic Touch with 1 single antiplatelet therapy. We have a case series of 20 patients, around 20 patients, with a 6 month follow-up, and the patients are faring very well with no thrombotic issues.
Because Sandeep is going to give us some real-world experiences, show us some cases, and then we'll comment further.
Thank you very much, Martin, and good afternoon, everyone. First of all, I would like to thank the TCT and Concept Medical for giving me this opportunity to share our experience with Magic Touch. So my name is Sandeep Basavarajaiah. I'm a cardiologist in Birmingham in United Kingdom. So I do not have any conflicts of interest to declare. So in this presentation, I would like to focus on the indication for DCB in my clinical practice, where I want to choose a DCB over a stent, and show some data from our center, which has been published recently, and also some interesting cases. This technology in 2018, and so far we have used in over 400 patients. And in this retrospective analysis, we would like to provide the data from our center and also from Harefield, London, from March 2018 up until February 2019. So we had around 288 patients with a mean age of 66 who were treated with Magic Touch. If you look at the demographics, the most highlighting thing is the diabetes, which was prevalent in up to 40% of patients, indicating generally small vessel long lesions are seen in these kind of patients. We had around 10% of patients with CKD, and more than 50% of patients who were in the setting of acute coronary syndrome, and around 46% in the setting of stable angina. In regards to procedural characteristics, we had more than 60% lesions were de novo, but we also had up to 40% of patients with restenotic lesions. Pre-dilatation was performed in 92% of cases, mainly with a semi-compliant and non-compliant balloon, but we also had some patients treated with the scoring, cutting, and rotational atherectomy. In fact, in the last 6 months, we are increasingly using scoring balloon and cutting balloon, especially in de novo lesions. Procedural characteristics, most of the lesions were in the LAD and diagonal system, followed by circumflex and right coronary artery. But we also had some cases where we treated the vein graft and left main stem with DCB Magic Touch. The bailout stenting was relatively low, 9%, and there were half and half between flow-limiting dissections and a recoil of more than 50%. The mean diameter of the DCB was 2.8 millimeter, indicating these are small vessels, and the mean length of the DCB was 28 millimeter, indicating these are long lesions. So we had a median follow-up of a year, and all patients had a minimum of 6 months follow-up, unless they died within the first 6 months of the treatment. So if you look at the overall death was 3.4%, but the hard endpoints like cardiac death was low, less than 2%, and the target vessel MI was 3.4%. The TLR per lesion was 12%, and the overall MACE, which was basically a cardiac death, target vessel MI, and TLR was 10%. We had no documented case of acute vessel closure, which means within 24 hours of the procedure. If we just look at the de novo lesion subset, we had 186 patients. Again, it's a small vessel, mean diameter was 2.4 and relatively long lesions at 23 millimeter length. And the clinical outcomes in this group are also very good, with a very point. And the TLR was 9% and the overall MACE rate was 6%. We have published our experience a few months ago in CCI, which came out, and it's available online. With this, I would like to show some case examples. So this is a case of a 62-year-old man who presented with crescendo angina in the background of previous angioplasty to LAD in 2005. His risk factors included hypertension and hyperlipidemia, and he also had a preserved LV function. The angiogram demonstrated restenosis within the previously placed stent and more disease distal and proximal to the stent, and it was very calcified, as you can see from this angiogram. And you could appreciate in this still picture. So we tried to treat this lesion with the NC balloon first, and then when we went up upstream, there was a dog bone effect, so it was not yielding even with a high pressure. And then we upsized the balloon to 4 millimeter NC balloon, and again, despite going high pressure, we saw this concentric dog bone effect, and the balloon burst at this atmosphere. So we did an IVUS, which you can appreciate there is some restenosis in the stent, but as you came more proximally, you see a concentric layer of calcium where the balloon was not yielding. So obviously in the past, we would have taken a OPN balloon, which is a high pressure balloon with a separate indeflator. But because now we have a IVL, so we used a 4 by 12 millimeter lithotripsy balloon, and we had a good crack of the calcium. And this is the IVUS post IVL, and you will appreciate there's a crack in the calcium as you come more proximal to the calcified segment. And if I show this in the still pictures, these are all the calcium which have been cracked with the IVL. And then we used a 4 by 40 millimeter magic touch here. And we had a good result. And patient had some moderate disease in the right coronary. So he came back 4 months later for a stage assessment. So the follow-up angiogram 4 months later shows a good result in the LAD, although there is some recoil. So we checked the IFR, it was 0.95 here. So we opted not to do anything at this stage, and patient was asymptomatic. Second case is even more interesting. This only happened a few months ago. A 70-year-old man with inferior myocardial infarction with no previous cardiac history, risk factor, hypertension, hyperlipidemia, and smoking. He had some moderate disease in the mid-LAD, but no other major disease in the left system. The culprit was the right coronary, which was ectatic, and you could appreciate there is a blocked marginal branch here. And also the ectatic segment is here. And if you look at the AP cranial view, you will appreciate there is ectatic segment with thrombus in it and a slow flow in the distal vessel. So first thing, we crossed into the distal RCA and also into the marginal. We ballooned the marginal ostium with a 3 millimeter non-compliant balloon, and we used a 3 by 20 millimeter magic touch in the marginal branch. Now, for the distal vessel, obviously we had problem. One is ectasia with a big size mismatch and a lot of thrombus in it. So we wanted to avoid stent here. So we gave GP2B3 inhibitors for patient and used a non-compliant balloon, and followed by 2 magic touch, 3 by 15 in the distal and 3.5 by 20 in the proximal segment. And the post magic touch, we had a good result, TIMI3 flow, probably all these spasms in the distal vessel. So we opted not to intervene. As I said, he was given 12 hours of GP2B3 inhibitor. And since he had a moderate disease in the LAD, he came back 3 months later for a pressure wire assessment. And at the time, we took a picture of the right coronary and we were impressed with the result. As you could see in the LA view, the marginal branch is open. And if you look at the AP cranial view, the RCA is open. All the spasm has gone, the TIMI3 flow, the ectasia is still there, but we had a good result compared to what it was when he came in. The last case is also very interesting. I think some of you have seen this. This is a patient who had a vein graft to LAD inserted a few years ago when he had a mitral valve repair. You could see the mitral valve ring. He came in with a crescendo angina, and the stress test demonstrated ischemia in the LAD territory, and you could see there is an insertional stenosis where the vein graft joins the LAD. So the problem treating here with a stent is, one, there is a big size mismatch. Second, if you do put a stent in from vein graft into the LAD, you close the option of opening the native LAD if the vein graft goes down in the future. So we wanted to preserve the option. So we ballooned the insertion point with a semi-compliant and a non-compliant balloon. And then we use a 3/15 Magic Touch. And we had a final result like this. There is no significant recoil or dissection there. And this is the comparison between the pre-treatment and the final result, which is acceptable. And patient was fine up until 18 months, after which he had some chest pain, which was not very classic of angina, but because of the vein graft intervention, we thought we will recheck the angiogram. So this was 18 months later. And as you can appreciate, the insertion point which we had treated looks very nice. And if you compare the two, that is post DCB on the left side and the follow-up, you could see the positive remodeling of the vessel. So in conclusion, DCBs are excellent alternatives to stents, especially when they're not desirable, like a restenotic lesions, small vessel diffuse disease, ostial side branch, and patient unable to take DAPT for an extended period of time. So from our experience, Magic Touch, we have had a low rates of hard endpoints. As mentioned by Bernardo, any new technology, we have to subject to intense scrutiny. So one thing I can say is that Magic Touch is safe, especially in regards to hard endpoints with low rates of cardiac death and target vessel MI, especially in our real population. Acceptable rates of TLR and MACE, considering the population, which was very complex. As you saw, there was a 40% diabetes, more than 50% were in the setting of acute coronary syndrome. We had long lesions, small vessels treated. The results are encouraging, although we need more long-term data, and the follow-up is ongoing. And also we are part of the RCT, which is being designed by Professor Serruys, and we are looking forward to it. And thank you very much.
I have two quick questions. You discussed 4 different indications: in-stent restenosis,
yep.
Diffuse disease in small vessels, branch osteal disease, and then perhaps high bleeding risk scenarios. Overall, about what % of your PCI population do you think would be good candidates today? So we're talking about 10%, 30%? Do you have any sense?
A good question, Martin, because when we started using DCB, I think it was 10%, I would say. But then with the growing experience and follow-up angiography, seeing our outcomes, now we have gone up to, my practice almost up to 30% I use DCB, sometimes in combination with the stents. So for example, if I'm treating a distal left main bifurcation, I tend to avoid putting a stent in the circ ostium. So I use a DCB in the circ ostium and stent the main vessel left main to LAD. So it's sometimes in combination, but overall, I would say 25 to 30% of the cases are with Magic Touch or DCB.
Mm-hmm. That's a good number. That's very interesting. The second quick question is, you mentioned that almost half of the patients were acute coronary syndrome.
Yeah.
In your case too, you showed a significant thrombus burden. Yeah. And I wanted to know from your experience, and Bernardo and Antonio, so it doesn't seem that thrombus in any way is an important, even relative contraindication for DCB. Is that a correct statement?
Well, I'm not so sure about that, but the reason I avoided stent in that case particularly was because of the ectasia. I wanted to avoid stent mainly, but most of our primary angioplasty are still with drug-eluting stents. So I don't know whether thrombus has any bearing with the DCB on its own, but I probably say answer is no. I don't know what Dr. Colombo and Bernardo thinks.
But, Sandeep, congratulations. I totally agree with everything you said. I mean, we are doing very similar. Our current use of DCB is about 25 to 30% of PCI. So it's amazing how we are so close, even if we are so distant geographically. The only difference a little bit is that we use physiology more because we tend to leave more dissections unstented, and we only do that if physiology is very reassuring. Otherwise, we stent. But congratulations, very nice work. I think in 1 year, I believe will be time to do a good randomized study, but so far we need to learn more.
Thank you. Just
Yeah, but you've
sorry.
No, please, I was just saying, you've seen 3 of the largest series of drug-coated balloons now with some really high-quality data for observational registries and some great case examples. So I think this is a little bit of the appetizer as we build to the finale. And when we talk about the finale, then we always talk about Patrick. So we're delighted to have Patrick join this symposium, and he's going to elevate the science a little bit, and is going to talk about a randomized trial that he's helped to design with Magic Touch called Transform. So Patrick, please enlighten us as to what we can look forward to.
Thank you very much, Marty, for this kind word. It is indeed a randomized comparison between the Magic Touch and the sequent Neo for the treatment of de-novo coronary artery in small vessel. And you know, small vessels sometimes is a misnomer, so you really have to be sure that you have a small vessel. Have no financial conflict of interest with this topic. I start immediately by the flow chart of the trial. As you could see, the first inclusion criteria is basically what is still available easily in the cath lab, is a QCA with a vessel of less than 2.5 or 2.5. And you know that the OCT will find in this vessel potentially a 2.8 is generally 0.3 more than the QCA. Then you have a pre-dilatation with 2.25, 2.5 balloon. If you have no angiographic dissection type C, D, E, F, and a TIMI flow of 2, then you randomize. The power calculation has been made on 114 patients, 57 in both groups, Magic Touch and a sequence of B. Brown. And then you have something which is quite unique, which is the influence of Antonio, Bernardo, and the people involved in this trial, Carlo Di Mario, Sandeep, and others. We do an OCT post pre-dilatation. So you do the pre-dilatation, you do the post. Just to confirm that you are dealing with a real small vessel, that's point number 1, and then to have some good guidance for the use of the DCB, Magic Touch in one side and sequence in the other. And then basically we have the QCA at 6 months, which is not about late loss, but which is non-inferiority in net lumen gain. And the reason for that is that the drug coating balloon we have seen can induce a positive remodeling and a late lumen enlargement, which is not the case of the stent, which cage the vessel and you can only have a late loss reduction. And then there is a clinical follow-up at 1 year. So it is interesting because the primary endpoint is the per protocol, looking essentially to the patient who have indeed on OCT a vessel less than 2.5. And of course, the whole population will be in the intention to treat. So it's a good organization. It has been a good discussion between Antonio, Carlo Di Maio, Luca Testa, Sandeep, they have just heard, and Hélène Rutledge. Bernardo and myself, we try to help the clinician in the field, and Antonio is the principal investigator in Maria Cecilia in Italy. So this is a case of Antonio. As a matter of fact, it's the first case, 62 years old, male. You could see that in the segment 9, which is a quite long, nice LAD, there is a very focal lesion. I must say that the case made by Antonio was a perfect selection of the case. It really fooled to start the trial that time. You see here the still frame on these diagonal, very focal lesion, 3 beautiful angiographic view, which allowed us to do also the QFR. Here you see the Colab assessment of the QCA, MLD of 0.83 millimeter, reference diameter 1.7, maximally 1.89, proximally 1.86, and distal 1.75, just to be sure that we're going to select not only on QCA, but on OCT, the right dimension, diameter stenosis 51, area stenosis 83, and a short lesion. So what you see here is the result of the pre-dilatation. Antonio took a non-compliant balloon at 18 atmosphere, maximum balloon diameter 2.5, and the length of the balloon was 20. And then after the pre-dilatation, before the randomization and the drug coating balloon, you have the assessment of the dissection, who cannot be CDEF. Just to remind you is that type A and B is some kind of luminal haziness, minor radiolucent area, no persistence of contrast after the dye, and type B is linear dissection. We didn't take type C, although I liked the type C a long time ago. I said that type C is a treatment dissection, but we want to avoid any serious problems. So this is, in this case of Antonio, it's an angiographic dissection type A, eligible. Here you see the OCTs, distal, and then you could see, I'm going to play a few times, you could see the classical treatment of balloon angioplasty, which is the fracture of the neointima with a kind of dehiscence of the neointima from the adventitia. So the mechanism of the dilatation is there. If you look very carefully, there is a complex lesion. I will show you that on a still frame with a combination of some plaque of calcium and some fibrotic lesion. But the goal here is really to assess the dimension of the vessel, proximal and distal, at a site where the vessel is not severely diseased. You could see in the distal reference, we have an average diameter of 1.87 and an area of 2.74. You have the MLA, you have the site of the dissection. As you could see, you have these dehiscence of the fractures and the dehiscence of the plaque media. Between 9 o'clock and 11 o'clock, you have a calcified plaque when you see the edge of the plaque, and then between 12 and 3 o'clock, you have something must be fibrotic with not too much attenuation. The proximal reference is 235 on average, with an area of 4.33. So what is a little bit tricky is that if you look the Magic Touch versus the Sequent Please Neo PCB, is that they have somewhat in their label different way to recommend the selection. In the case of the Magic Touch, basically you use the lumen base approach at the top of the cartoon, distally and proximally. And you have seen you lose the distal reference, which was 1.87, and you can have a drug coating balloon, which is just less than 0.25 millimeters more than the 1.87. In other words, you would select with the Magic Touch a 2 millimeter balloon. In the case of Sequence, in the labeling, it is said that you have to take the mean difference, and then they use the EM-based approach partially. So you have to use the lumen 1.87 and 2.35, 2.11, a diameter close to 2.11. So theoretically you should select a 2 millimeter. So what did Antonio? I think that he made the right choice. Technically, the protocol would have recommended a 2 millimeter balloon and go up to a pressure of 14 atmosphere. I think Antonio did the right thing. He took 2.5 and he went to 14 atmosphere, which is 2.70 with the Magic Touch. So certainly stretching a little bit more the vessel, but having definitely a good apposition of the balloon during the drug coating. Between leaving the catheter and reaching the lesion, there were, according to Antonio, 3 seconds, which is possible because it's a straightforward motion, and in the catheter you have basically some contrast. The blood came after that. And the DCB dilatation time was 70 seconds. So this is the final result. You can appreciate the beauty. There is certainly no increase, no worsening of the so-called type E dissection. Of course, these days we look at QFR pre-procedure and post-procedure. They are small vessels, secondary side branch, so the amount of myocardium subtended by this vessel is not always major, but as you could see, the QFR was 0.84, and post-procedure, it was fully normalized. So that slide summarize and show you pre and post. The summary of the, I think it was a very good case with normalization of the physiology, side selection of the right dimension of the balloon, which is a very good issue, and then a typical mechanism of balloon angioplasty, which is the fractures of the neointima. That's it for today.
Very interesting. Again, as always, a creative and novel trial design. So the pre-OCT, which is after dilatation, is to confirm vessel sizing and to help size the DCB, to get the correct DCB size. So you're not right. And post, the only thing you're doing is QFR.
That's correct, yeah.
So does the operator know what the QFR results are? If the results are not ideal, is there an opportunity to optimize based upon QFR, like what Antonio does with his physiology?
Yeah, I think that the physiology is not part of it. I mean, there's always a constraint, financial constraint at the level of the sponsor of the investigate. So here we thought, okay, let's use the OCT to do the guidance for the balloon, which is probably the most important. Now, if the QCA is not satisfactory post-procedure, either there is the option to have further dilatation, eventually a second time the drug coating balloon, and as usual, if it doesn't work, you can always stent that lesion. That's the bailout stenting was estimated from many different publications. I think we didn't make it too high or too low, so we'll see what is the reality of the real numbers in terms of bailout stenting.
And this is meant to be a non-inferiority design based upon 6 months QCA.
It's a non-inferiority design, yeah, that was on the slide, yeah. Based on the gain, yeah. For the reason that I give you is that you may have some nice remodeling. The vessel can basically get bigger than it was initially in the reference segment, yeah.
So I was going to ask you or Antonio or Bernardo, Sandeep, you're all involved in designing this study. I would imagine the next step, if the results are positive, as you continue to learn, that you might want to consider randomizing against what many people are currently doing, which is putting DES in small vessels. So, to me, that is obviously a provocative next step because that would certainly change clinical practice.
Yes, Marty, we are working on this. We are designing a study comparing current era DES with Magic Touch in native vessel disease. So you hit the topic.
But, you know, if I really see the confirmation of a very low, like Sandeep showed, almost zero occlusion or close to that, and I see that Limus gives you a late loss below 0.20 or around 0.20, then I will have difficulties to randomize to a stent, honestly. If I will take a stent only if the result is mediocre, but if the result is excellent, I mean...
Yeah, I think it's a good point. I mean, Bernardo has shown this slide with a late loss of 0.09. That's basically what we had analyzed from his patient in the Corelab. And of course, these 0.09 is a little bit of mixtures of some with late loss and some with late lumen enlargement. That's the reason, but it's a numbers which is extremely competitive in terms of late lumen loss in large vessel treated by stenting. Yeah, so I think that your remark, Antonio, is certainly justified. So
well, this is going to be a fascinating study. Any comments from any of the you know, it's interesting because I'm the only one from the United States, and we don't have DCB. The only DCB we have is if we take a peripheral DCB and we put it into a coronary for recurrent in-stent restenosis. That's the only application for coronary DCB in the US. So we are a few years behind you, but we will have in 2021 Magic Touch, maybe some others that we'll start studying in the US. And we want to learn from you, and maybe when you finish Transform 1, we can join you for Transform 2 on the next trial with some good US sites who would really love to explore this idea of minimizing stent use and trying to understand if the combination of imaging, physiology, and a non-stent but local drug delivery approach like DCB could be advantageous in many patients. So this has been very exciting. I want to thank once again Concept Medical for supporting this e-satellite, all of the faculty who were very, very honest and provocative and showed great examples. And I think this will be instructive to the audience to see what is really on the edge of where PCI is in 2020. Thank you very much on behalf of TCT.
Thank you very much.
Thank you, everyone. Thank you very much.
Bye, everybody.
Bye.